Thank you guys for inviting me. I'm glad to see people here. I thought Vegas at 8:30, there's no way anybody's going to be here. So I'm just going to kind of give you the evolution of how I was invited. I don't have any conflicts of interest. I do have some disclosures, though. We do intra-op at our North County office, and we just had Bill Small, who I went to medical school with, come talk about the different products or the different vendors, let me put it that way so that I'm not saying a word out loud, so that we could choose for the La Jolla office, because we just opened an outpatient pavilion and need to choose what we're going to do for intra-op. So how did I get an invitation? That's how. I got an email from Bill, Dr. Dave Gaffney and I did, and I'll show you the email. Really? This is what the ABS to do? My thought is to resign my membership and consider having others do that too. What? So then he showed us. So this is a statement that was in something called Brachybites. And I'll let you read it. I won't read to you. But basically said the specific form of IORT was recommended not to be used unless there's a clinical study. And sweet Dr. Gaffney goes, Bill, Brachybites is not published by the ABS. Why are you going to resign from the ABS? What pushed your button? And this is where the information from the Brachybites. So I'm here to talk about this, to defend this. You'll notice my name is not on this, but I am the president of the ABS. And so even though everything doesn't come through the board, it actually gave me an opportunity to go through, and we'll walk through these guidelines with you and kind of at least give you my thoughts on those. So here I am in my Target dress at the Target meeting as the target of all ire today. So this is the table in question. I know it's really, really small, but there's not really any way to make it bigger and have the whole table. But you can see on this left side, it talks about the kinds of brachytherapy, the pros, the cons, the recommendation, and then the last one is utilization. So recommendation being strong for the top two, moderate for the middle two, and weak for the bottom three. And I outlined where they put intraoperative radiation therapy. Oops. Let me go back. This slide was just, I know you guys have got to be annoyed about what the ABS said, and I've certainly been there. And the strange, ironic, disappointing thing is every person that's on that paper, except for the younger people, remembers when they were in that same situation, right, where everybody was saying it's terrible, women are dying, how could you do partial breast, that's crazy. You know, and I remember when this paper came out, I was really annoyed. And the thing that annoyed me the most was not that they showed something, was that they used really pejorative terms like, for every 56 women treated with breast brachytherapy, 1 woman was harmed with an unnecessary mastectomy. And I thought, really? Is that the way a scientist writes? Or is that a vindictive kind of thing? And really, at the top, you see at 5 years an absolute 1.77% excess mastectomy, which of course has not been borne out in any of the studies. But in the headlines, if you guys remember, it said mastectomy rate is doubled, which is a much scarier headline than you might have a higher risk of mastectomy if your tumor recurs and if you don't want another lumpectomy and radiation, which we now know, of course, you can do. So there's that number. So this is the recommendations. I'm just going to go through these. So they talk about, this is interstitial, and they're talking about it's strong because there's 2 randomized trials with mature follow-up. And they're saying, and it shows better cosmetic outcomes, so we think that that's got strong recommendation that this is something that people can do. And this is actually APBI IMRT, which I don't do and didn't realize that they would do a strong recommendation, but again, they did one based on a randomized prospective trial. And I know you guys are thinking, hey, what's target? But we'll get there. Applicator brachytherapy. So I did interstitial, and I still do a decent amount. Then I switched to single entry devices, which I still do a couple of times a week. It only got a moderate, and that's because there's not really any randomized prospective trials with the applicators. You know, when B39 comes out, it'll have some applicators in there, but really it's only going to be about 20% of patients, so we'll see what that shows. And then IORT was given weak because of lack of data demonstrating equivalent local control compared to whole breast radiation therapy. Now, before you start throwing things at me, let's walk through and say why they say that. So there you are, me as Bush getting shoes thrown at me. So look at all these methods of partial breast. I mean, it's really an exciting time for partial breast. You know, we can have all these things to choose from with variable amounts of data. And as Bill and I talked about at dinner last night, you know, women are often educated about their choices. Sometimes they're not, and that's our job. But they can understand the difference between maybe an increase by 1.5% that you would get a mastectomy, and a lot of them can make informed decisions. So I think we can't discount the informed consent part of all of these methods. So just to look at the data, you know, here we've got the 9517 phase 1-2 multi-catheter APBI with all the people, well, some people were just in RTOG, but others that started the whole partial breast there. And you can see that the 5 and 10-year recurrence rate is really, really equivalent in this, right? You know, there's not really any difference in field, out of field, and so this really led to some embracing of partial breast radiation therapy, even though I would say that Astro was forced by the weight of the data to recognize it. And then Jack Estro came out, thank goodness. 1,100 patients, major endpoints were local recurrence and late side effects for all of those that were enrolled. And there was not anything statistically different, and you can even see those numbers are not very different. And they divided it up like we do in subsets analysis, which is not the primary endpoint, but just as an exploratory. And the 5-year ipsilateral breast tumor recurrence was 1.4% versus 0.92%. And then these, I thank Julia White for putting all these tables together, so I do have to thank her for this slide. And as you can see, all of these people, and look at the follow-up, for interstitial. I mean, there's no doubt that the wealth of follow-up for these, and it just gives you kind of a summary there, local recurrence, about 4.6%, and that's with really long follow-up. And so this is why it got strong, right? These single entry catheters, and you can see that the theme for my slide is the target. Savvy, Contura, single entry, all of those. And you can see those, and the follow-up is much shorter. And there's no randomized trials there, but again, showing local recurrence rate of about 3.5%. And so it got moderate because there's not really any randomized prospective data. External beam, not a big fan. I haven't tried IMRT, but they did have this, as a phase 1-2 trial. There's the follow-up of 3D conformal and IMRT outside of the randomized prospective trial. Again, our follow-up is kind of getting lower and lower, again, showing the local recurrence rate. And this also got a moderate, except for the IMRT. So the IORT, and the advantages are localized therapy, direct visualization of target, it's convenient, one procedure, less travel, but there's some disadvantages. Is that enough dose? Time will tell. Pathology unknown at the time of treatment, additional OR time, dosimetry and conformance, and what about this local recurrence rate? And I have to tell you, as medical director of radiation oncology, when my doctors go to do an intra-op, we don't talk about this very much. It costs us a lot of money. They're not doing other things. They're not making other RVUs. When they do 2 or 3 cases, they're gone almost the whole day, sitting outside the OR. And as the medical director tallying up those, that's not a small thing to me. We are getting one in La Jolla, but I said, I will only do this if you've got 2 computers outside the OR where the physicist and I can sit and do other work. And so if I don't structure that correctly, then it's great for the woman in many, many respects, but it's not really great from a business model. Great for the insurance companies, great for the nation in many ways, but it has to be thought out. And this trial hurts intra-op. It flat out does, because you look at the ipsilateral breast recurrence rate was 5.3% to 0.7%, and we know that these were higher risk people, and we know that all of the downsides, but unfortunately it gets lumped into the same category. And then the target trial, follow-up in the publication was pretty short. In-breast recurrence rate for all comers did not reach the endpoint that we wanted, right? And so we divide that into the pre-pathology and the post-pathology, but then we're doing that subset investigational hypothesis generating, and not that that's a bad thing, but we criticize it in other studies, so we have to be fair, and I'm a huge partial breast fan. We have to be fair about what the data shows. And again, adverse clinical pathologic factors, this is going back to the Elliott trial, increase ipsilateral breast tumor recurrence. We don't dispute that. And so this is kind of the IORT data. And then this hurts, right? What's his name? John Cusick. I'm glad I don't know his name. That I'm not going to read it to you because I know that you guys all know what he wrote. And true or not, whatever was going on, we don't know that, but everybody read this. And so, the talk about pre-pathology, sometimes even today, and I've really, really enjoyed this conference, when Dr. Vaidya was talking and showing his data, I kept thinking, are you talking about everybody? Or are you talking about the pre-pathology or the post-pathology? Whenever I hear talks about this, I want to know, are we talking about the pre-pathology? Are we talking about post-pathology? Or are we talking about everybody? Because there's so much talk about the different groups. He talked about 5-year survival without local recurrence, and that's really, really important, right? But we know that in an older woman, we're probably not impacting survival, and it's important to the woman, but you still got to you can't not talk about local recurrence, because that's what we talk about with women, right? That's what we talk about when we're talking about tamoxifen versus tamoxifen and radiation. And then if you do subset after subset after subset, that's not the primary endpoint. You have to make a distinction between what is hypothesis generating, and I need to take this thread and follow it out and see what the truth is. But it's not necessarily fact, right? It's hypothesis generating because it's a subset analysis. And then when do you choose? Like the cell motion data, that was really cool, but I don't care if the cells can't move. I want to know that they die, right? Who cares if they're wiggling or not? I want to, and again, I think these are all great things to prove. And that's why we have scientists, and that's why we're scientific. And so you can slice a peach, and you can make it look like a rose, but it's not a flower, right? So we just have to be careful between what's real and what's not. So this is what makes people nervous, right? These are the recurrence rates. Elliott, much worse, and Target. They look like they're diverging. And again, time will tell, and I don't know that we need to be in such a rush. So education, again, we talked about this, and informed consent. A woman may not choose APBI because the mastectomy rate was increased by 1.7%, but lots of women did. When that came out, I felt compelled to talk to women about it, and I must say that's not what drove down my partial breast rate for a while. What drove it down was oncoplasty and putting things in where I couldn't put the devices in unless I did interstitial. And I think we just have to be honest about the recurrence rate and the impact on survival. I have lots of 72-year-old women who don't want to have radiation, and I'm like, fine. Your recurrence rate's a little higher, but you're not going to die of breast cancer, so I think that's okay. So look at all, what makes it even more confusing is we can't even decide what our consensus statements are going to say, which I'm not sure why the ABS, and obviously that's partly my responsibility now, and the ASBS and ASTRO can't get together and come up with one set of guidelines. I mean, with ASTRO, there's not even a brachytherapist on the guidelines. I think that's interesting. So I have always gone by the ABS guidelines because, of course, they came out, and the ASBS guidelines came out long before the ASTRO guidelines came out. So I've done lots of women that were in their 40s. I've done DCIS. I've used 3 centimeters, not 2 centimeters. And I must say the only ones that I shy away from now, and again, this is a good role probably for intra-op, are diabetics, because at least with the 5-day course, the ones I've had like 5 infections, and they were all either diabetic or smokers or were diagnosed a few months later. And so I shy away. Now, we just finished the Triumph trial, which is you put the catheter in, you treat that day, they have the catheter in overnight, you treat twice the next day. I've done that on trial on a couple of the diabetics, and I think that'll be a game changer for people that can fit the dosimetric criteria. And the ER negatives. I've had a couple of recurrences with those, so I'm just kind of waiting to see what NSABP B39 shows. Consensus statement from the ASBS. We've got the JEC estro, and look, they use low risk, intermediate risk, and high risk. Again, what do those mean? They're high risk for recurrence? We don't know that. They certainly didn't know that before they made the guidelines. Why did they use those words? The astro, unsuitable. Cautionary, why did they use those words? And again, part of it was the unsuitable they wanted you to put on the trial, because remember when these came out, the trial was still open. And you could think of other things to say. And these are the updated guidelines, and again, are much more strict than the ASBS and the ABS. This, I'm sure, doesn't make anybody happy. talking about clinical trials, and really saying that you'd have to talk to people about the local recurrence rate and the possibility that it might be higher, especially if you take Elliott into consideration. Now, we have additional phase 3 trials that are going to build on our current findings, and that's a great thing. Time will tell. 14,000 women about to be presented. Are there implications? And I think that's what we as physicians have to be careful with, because we know that we're not the only ones reading these. You know, the insurance companies are reading these and limiting women's choices based on not their interpretation of the data, on the words that we use when we publish data. Is it biased? Certainly, I think the language could be a little more scientific and a little less biased. Does it annoy you? Of course. If you've been in the partial breast world, unless you're new, you're annoyed, right? We're all annoyed. But the truth will out, and that's the really good thing about this. So everybody can make a prediction, you know, mean predictions. There was a prediction that all the computers would crash in Y2K. I know the younger people don't remember that. We were all prepared for the whole world to shut down. And Nostradamus and the end of the world, and the universe revolved around the earth. All of these were just predictions that were proven false with science. Intraoperative radiation therapy, what's the prediction? It's taking a lot longer than I thought, sorry about that. That it's evil. But facts are stubborn things, and whatever may be our wishes, our inclinations, the dictates of our passions, they cannot alter the state of facts and evidence. And that's why this conference is great, and I've really enjoyed all the presentations, and we really need to follow those threads and prove some of these things. Because, you know, when I hear about the heart thing, I think, you know, that's really interesting. It's something we should prove, but really, if we were bumping people off in 5 years, wouldn't all of the data, wouldn't the prime data have showed us that? Wouldn't the, you know, we have 12 years of follow-up now with the ECOG study. Wouldn't we have seen that those women were dying, the ones that only got tamoxifen versus the ones that got tamoxifen and whole breast radiation therapy? It just, I find it, with the wealth of data that we have over the last 30 years, I would find it surprising that we hadn't noticed that we were bumping people off in 5 years before now. Now again, maybe we're wrong, maybe we're wrong, but maybe it's just a statistical fluke that it ended up with that. And so I think that has to be proven in a more rigorous fashion before we accept it as fact. One size doesn't fit all, and we keep trying to put people in this one-size-fit-all buckets, and certainly not just radiation oncologists. GYN oncologists have been trying to get rid of radiation for years. It's or chemo or radiation, not both to their strength. So I think we need to stop doing that as scientists. So despite the differences, the absolute clinical difference in ipsilateral breast tumor recurrence may be an acceptable trade-off to some women, especially if now we know we can do salvage lumpectomies and whole breast radiation. I've had one woman now that's BRCA positive that I did partial breast on one side, then I did partial breast on the other side, and now I've done whole breast on one side, and I'm on the other, you know, so now one breast has been treated twice. I'm like, okay, you get one more chance on the other side, and then I'm gonna have to call it quits. So, you know, we've got things, great things that we can do. So the pejorative terms that we need to use more judiciously in scientific analysis. And when I was looking back at this, I thought, that's the real take-home message. We shouldn't use words like weak and unsuitable and harm and cautionary, right? We shouldn't give the insurance companies and other people words to attack us with. We need to use things like, this is an exploratory subset analysis and it's very hypothesis generating, we're going to follow it. You know, how many of them can know what we mean when we say that? We await further follow-up to confirm these findings. I mean, we have lots of ways that we can say it that are scientific and not pejorative. We can do friendly fire when we do the debates, but we gotta stop like shooting each other and taking each other down. So there's no reason to do that. So now, the movie, he's hearing. Oh, there's a little movie in here. You guys can show, I love this picture. Isn't that hilarious? And he's laughing. Like in between he starts laughing and he dodges it twice. If you guys want to throw shoes at me, I'll try to dodge them. Anyway, thanks for the invitation, I think, depending on if you throw shoes at me. And it's nice to be here as your target. So thank you.